The next session is on MDS Classification and Prognosis. I'm Robert Asurgian, and my co-chair Mir Zedan is here, and we have a nice, I think, lineup of talks here. As I think we're all aware, there's been a lot of advancement in the way we classify and diagnose MDS, but it is a bit of a transitional period with increasing infiltration of genomics in how we classify and diagnose MDS, and a current complicated situation of having two classifications, which we'll hear about. So I think the purpose of these talks is to kind of think forward and how we can improve how we classify, diagnose MDS to ideally, have better, devise better therapies, target therapies better to individual patients, and ultimately improve their outcomes. So we have some time devoted at the end for discussion. I'd ask to reserve all questions until the end, so we'll have enough time. But hopefully we can have a lively discussion that these talks will foster and how we can think forward and improve the next classification of MDS and prognostication looking forward. So with that, I'll introduce the first speaker, who's Mina from Yale University, who will be speaking about MDS classification, WHO versus ICC.
I thank the moderators and the organizers for inviting me. I have the pleasure of giving this particular talk, which I know fills a lot of people with dread, so I would definitely not be offended if people have to get up and get some more coffee. But I can say that it only gets better in this session. It only gets better after this. So I have no conflicts of interest with this particular talk, and in all transparency, I'm not senior enough to really be involved in the initial schism, so I think I can speak from a fairly unbiased point of view. This is a famous quote, as you know, which I cannot put in front of a bunch of pathologists because I will be attacked. But let's remember that actually it ends in a positive note. I do not expect the house to fall, but I do expect it will cease to be divided. This comes from a review that Rob and I had worked on recently, which actually has some very practical tables. I actually leave right near the sign-out scope because it gives you that overview of where it moves from our prior 2017 fourth revised classification of WHO onto the new WHO5 and ICC. So for these are all the low blast MDS, by the way. Single and multilineage dysplasia is kept in ICC and is lumped in WHO. For the WHO, there's a new term, hypoplastic MDS, which I'll touch upon later. There is also SF3B1 being pulled out of kind of a murky classification of RS, and that is in both. However, if it's wild type SF3B1, you can see that for WHO, it still gives you a category of low blast with ring sideroblasts as long as you have 15% or more ring sideroblasts, and it goes back into the MDS NOS for ICC. TP53 also pulled out for both WHO and ICC, but there are some differences there, which I'll also get to later. Del5Q is retained, and MDS unclassifiable is eliminated. For the high blast count, EB1 and EB2 are IB1 and IB2 in WHO5, so not much difference there. But for ICC, as you know, EB is encompassing really EB1 in terms of the bone marrow, 2 to 9% in the peripheral blood, and for the and this is only for adults, by the way. For children, it's remained the same as WHO4 in terms of that classification. But we're really focused on the adult MDS here. So the AML is still kept at 20% or more. So the MDS/AML is reserved for that portion that is 10 to 19% blast in the bone marrow. And then we have AML defining genetics for both. The only difference there, well, there's more than one, but the main difference is that for ICC, you need 10% or more blasts. Furthermore, the TP53 also comes into play for the increased blast. And then there's the new MDS with fibrosis for WHO5, which really is about the EB1, EB2, or IB1, IB2, does not apply to low blast. So we'll start with a case. This is a 71-year-old woman seen at Yale with a history of CLL, quite long-term CLL with ibrutinib treatment. She's pancytopenic. We've seen a couple of prior marrows from her, which were markedly hypocellular. She seemed to have been suffering from bone marrow failure and was treated for aplastic anemia. However, cyclosporin was recently stopped due to poor response. So her new bone marrow showed normal cellular marrow. I'm not showing the low power, but it was a very good sample. Normal cellular marrow now, not hypo, and you can see a lot of iron there, a lot of hemosiderin because she was being transfused, not a lot of megakaryocytes. In the aspirate, you can see pretty substantial dysplasia in the erythroid lineage with nuclear atypia and megaloblastic changes. There were also ring sideroblasts. Overall, the findings were normal cellular marrow for age with megakaryocytes that were decreased, erythroid dysplasia, and also ring sideroblasts at 7%. Now, one of my colleagues who got this is a very avid counter, and so I really believe this 7% ring sideroblast from him. The flow showed no increase in blasts, and there were still a minute population of CLL cells. So what's your diagnosis here? I'm just going to take you through the realistic application of our criteria before and after the cytogenetics and molecular comeback, which for us is about 2 weeks. So initially he said, okay, it's dyserythropoiesis, it's got ring sideroblasts, and for WHO, I highlight in blue. So WHO5 is MDS with low blasts and SF3B1. If we were to get the SF3B1 mutation back, and for ICC it would be MDS with mutated SF3B1. So not much difference, right? In the prior WHO, which I cut out of this text because it was just getting too long, it would have been MDS with ring sideroblasts. Unilineage dysplasia. So cytogenetics comes back normal. FISH was negative for the MDS probes, and molecular finds an SF3B1 mutation level 1 at VAF of 3%. So now what is your diagnosis? For us, we were taken aback because this is not your usual SF3B1 in MDS. This was the MDS associated with CLL and not reported with MDS. So that took us for a little spin. We had to go back to that diagnosis, and for WHO5, it would be back down to MDS with low blast, for ICC, MDS, NOS with single lineage dysplasia. With a comment, of course, that this case is challenging given this patient's long course of aplastic anemia. Where do you really draw the line between aplastic anemia and MDS? And for us, we just had to follow the criteria. We did see dysplasia. It was pretty substantial, and that was the low blast diagnosis. So let's go through some hypotheticals. If the rings were 15% or more, for WHO WHO5, it would be MDS with low blast and ring sideroblast, ICC, no change. For SF3B1, the classic myeloid variant, we would get back up to the SF3B1 mutated MDS. However, the VAF needs to be 10% or more for ICC and no RUNX1 mutation. Just a reminder that there's always a lot of exclusions in these new criteria. And I actually enjoy reading the exclusions sometimes because it reminds you what are superseding diagnoses, right? What are the ones that make it worse? Because our job as pathologists is to give you the worst diagnosis. So if something trumps it, then we're going to go for that something. And I'll just take a moment here to highlight a study that is yet unpublished that Dr. Luca Lanino will touch upon later. And these are really large cohorts of patients that were reclassified according to ICC or WHO WHO5. And you can see here with the lines in dark green is the MDS with SF3B1 according to WHO, and in the teal is MDS with ring sideroblasts and low blasts. So you can see that with the teal line, it actually looks quite similar to MDS with low blasts. So kind of giving evidence that the SF3B1 is really what makes this a better prognosis MDS versus the ring sideroblasts themselves. And this is really from a couple years ago, and now there's over 7,000 patients, and the lines have not shifted dramatically. So I just refer to the one that is available publicly. So let's just shift a little bit on the topic and talk about TP53. The red lines are the MDS with biallelic TP53 mutations. And you'll see that in the purple on the ICC, so the much lower line, the lowest line there, is the MDS AML with TP53 by ICC. So that's the 10% or more blasts, 10 to 19% blasts, with TP53, either single or monoallelic. As most of you know, this is a study that showed over 2,000 patients with AML or MDS-EB, not split in terms of the blast numbers. And you can see how MDS or AML with TP53 mutation really run together in terms of survival versus the ones that have wild type. And this particular graph here, the figure is showing either mono or biallelic. However, 76% of their cases had biallelic TP53, the ones that did have mutation. This particular study did not find significant distinction with regard to biallelic alterations. However, this is a more recent study that showed blast counts are split out into greater detail. And you can see that for the low blast count on the far left-hand side, there are fewer multi-hit TP53 cases, which is, I think, experientially kind of resonates with most of us. And in those samples, having a complex karyotype was still an independent prognostic factor. However, when the total cohort was split based on TP53 state, only the blast count and not the karyotype, the complex karyotype, had independent adverse outcome. The blast count also does influence overall survival independent of TP53 state, even in those higher blast count MDS. And that comes into play in terms of our classification. So moving on to case 2, this is a 63-year-old man with pancytopenia, and he has a rather hypercellular marrow for his age, and he has marked dysplasia in megakaryocytes. You can see the nuclear atypia, you can see the hyperchromatic, kind of squish-looking megakaryocytes. The blasts were increased at about 10 to 15% by IHC. It was confirmed with the flow as well. The aspirate here was not so great, but we also did a P53 immunostain, which was markedly elevated in the 3+ high intensity, and this is very well correlated with aberrant TP53. But to give you a sense of what we would do without the molecular genetics at the up front is this is a myeloneoplasm with 15% blasts. So by WHO5, it's MDS with IB2, and by ICC, it's now that new nomenclature MDS/AML. However, we make note of our P53 IHC, and then when we got the molecular genetics back, this was about 2 weeks later, cytogenetics showed complex karyotype with loss of 17, and also, most likely due to the loss of 17, a very high VAF of TP53 mutation at level 1, and also a DNMT3A mutation. So now what is our diagnosis? This would bump it up, right? So like away from just the blast counting, but towards MDS with biallelic TP53, inactivation for WHO5, MDS/AML with mutated TP53. This schematic shows you where, what we need to get to ICC, this umbrella category of TP53 myeloid neoplasms, which encompasses all the different blast categories, whether it's low, 10 to 19, or 20% or more. So you definitely need multi-hit TP53 for the low blast, but you do not need that anymore for anything above 10%. You do need cytopenia and dysplasia when you have low blast, but you do need cytopenia and dysplasia for the WHO5, but not for ICC. So for WHO5, it encompasses 0 to 19% blasts, biallelic only, and for the dysplasia, you do need to see it in the setting of cytopenia. So I think I still have a little bit of time left. I'm going to just mention 2 additional new entities, one which is MDS with fibrosis, which is this category in the WHO5, not in the ICC, for anything grade 2 or grade 3 on reticulum fibrosis in the setting of excess blasts. Of course, no biallelic TP53 because that would pull it out into a worse category. And there's no known distinct genetic profile for these yet, but we know that they have a worse outcome, which is the reason for having it as a separate criteria. and also a hypoplastic MDS entity where you have bone marrow cellularity that are less than 20% if the age is greater than 70%, or less than 30% if the age is less than 70%. And they may have a better prognosis and more likelihood of responding to immunosuppressive therapy, as they kind of are on the spectrum of aplastic anemia as well as PNH. These, by the way, just to give some little shade to this diagnosis, you really need a good sample. Okay, if you have a very small core, it's treacherous. You can end up saying that, and it's not really hypocellular or hypoplastic MDS. I thank Rob for this slide in the deck, because I really thought it was brushing the rug a bit for both WHO-5 and ICC, where this list, this table, which is in the old WHO, is gone now. Okay, and that's a real thing. It is no longer there. So they've pulled out the del5q, del7, and also complex karyotype, and you do not need that in ICC. You do not need dysplasia for ICC when you have those findings. And this also includes TP53 and SF3B1, just to make that list complete for ICC in terms of no dysplasia, but molecular genetic findings that are sufficient for MDS. For WHO, remember, we need dysplasia for all of that. And then the others in that table, if you do not find dysplasia, is now CCUS. So just end on one note. So we have this case of myelofibrosis, and who has the last word? This case, I won't bore you with the details, but the patient had multilineage dysplasia. It was hypercellular, and blasts were increased at 10%. It's actually on Asper count a little more than 10%. So by WHO-5, it would be IB2. For ICC, it would be MDS AML. We get the reticulin stain in about 2 hours after the H&E, and we saw that it was increased at reticulin MF2 of 3. So by WHO-5, it's MDS-F, and by ICC, it's unchanged. We get our immunostain about 8 hours later, so we get the P53 IHC, and it's increased at greater than 10%, 3+. So by WHO-5, it's after getting the genetics back, which is biallelic, MDS biallelic TP53, and by ICC, it's MDS AML with mutated TP53. I'll leave you with this. In red are the new entities in the ICC and WHO, and I look forward to a unified classification system. Thank you.
So the next speaker is Lachelle from Harvard and Farber, and she'll be speaking about prognostication of CHIP and CCUS.
Hi, everybody. Thank you to the session co-chairs and the organizers of the meeting for inviting me to speak. So I have, these are my disclosures, not relevant to this presentation. So clonal hematopoiesis, I like to always start with definitions and some nosology. So we all know that somatic genetic events are inevitable and ubiquitous. So all of us have some level of somatic mosaicism at any time. Clonal hematopoiesis specifically refers to a type of somatic mosaicism that is age-related, where you have expansion of a genetically related population of hematopoietic stem or progenitor cells that can be detected in individuals who have none of the hematologic or pathologic features of a myeloid or other blood cancer. We know from work that Sid Jaiswal did when he was a postdoc in Ben Ebert's lab that the frequency of clinically detected clonal hematopoiesis, so we're talking varying allele fractions of 2% or greater, is increased with age, and that it is the sort of acquisition of second hit mutations or second hit genetic events that leads to the development of malignancy. There are many different subtypes of clonal hematopoiesis, so there are many different ways that one can go about acquiring this sort of advantage of a particular clone. What we talk about most are these somatic mutations, so mutations in driver genes that are associated with hematologic, particularly myeloid malignancies. And we just heard about the new WHO classification of myeloid neoplasia, which included formal definitions for clonal hematopoiesis of indeterminate potential, where you have no cytopenias, but a varying allele fraction in myeloid driver genes of 2% or greater. And clonal cytopenia of undetermined significance, where you have the molecular features of CHIP, but you also have a cytopenia, so anemia neutropenia or thrombocytopenia. There's also recently been definitions for lymphoid clonal hematopoiesis, so this is somatic mutations acquired in lymphoid driver genes. And then there's also this other entity that we talk about now because our technology is much better than it was in 2014, where we can sequence down to very low depths. And so we have variant allele fraction, clonal hematopoiesis that we can detect with variant allele fractions less than 2%, the clinical significance of which is not clear. There's also most of the clonal hematopoiesis that's detectable is actually unknown drivers. And so these are either epigenetic drivers of clonality, undetected drivers completely, or unclassified mutations. And then lastly, there are these mosaic chromosomal abnormalities, so low fraction changes in the chromosomes that are either lymphoid or myeloid drivers. Setting up the nosology of clonal hematopoiesis, so I like to think of CH in general as sort of this umbrella term that means a lot of things. And then when you sort of space it out, you have both myeloid clonal hematopoiesis, lymphoid clonal hematopoiesis, and also this entity CH with unknown drivers. When we get down a little bit further, that's when we start breaking things down into CHIP, CCUS, MCAs. And we talk more specifically about CHIP and CCUS because those have been the most clinically characterized. So why is this important? CHIP and CCUS are precursors to myeloid malignancies. This has been borne out in several publications over time. That if you have CHIP and CCUS, your risk of developing a myeloid malignancy is increased. However, we know that we can detect clonal hematopoiesis, so CHIP or CCUS, in individuals greater than 65 at a pretty high frequency, 15 to 20%, depending on which manuscript you're reading. But the rate of transformation is only about 0.5 to 1% per year. So if we think about the entirety of the United States population, which of those like almost 60 million US adults who are over age 65 and have CHIP and CCUS should actually be followed in our hematology clinics, or are these subspecialty CHIP clinics? So this is the question that we set out to answer when we were thinking about prognostication of CHIP and CCUS and understanding what the risk of myeloid malignancy and other outcomes actually is. So we published back in April of 2023 this paper in New England Journal of Medicine Evidence, where we laid out the clonal hematopoiesis risk score, which is a algorithm that helps us to estimate whether someone is high, intermediate, or low risk for progression from clonal hematopoiesis to overt myeloid malignancy. This work was derived using the UK Biobank, and we can talk about the biases that are inherent in doing so. But the UK Biobank is a population of healthy adults where samples were acquired between ages 40 and 70 years of age for 500,000 individuals. We have available sequencing of most of the population, so about 450,000 individuals actually had available sequencing at the time of this study. We were able to split the sample into a derivation and a validation cohort. About 11,000 individuals were in our derivation cohort with CHIP and CCUS, and about 16,000 in our validation cohort. Some of the characteristics of the cohort are shown on your left. The median follow-up time was about 11 and a half years. There was about 55% females. Very few individuals actually had a prior cancer history, and no information on chemotherapy or radiation exposure were available. And then also very few individuals actually had CCUS, only about 7.6%. There's a high smoking prevalence in the UK, and so about half of the population were smokers. What we learned from this is that the risk of incident myeloid malignancy seemed to be genotype specific, and so the crude rate of myeloid malignancy was 2.37%, and most of these were MDS AML. And then when we looked at the risk of myeloid malignancy using regression models to determine hazard ratios for myeloid malignancy, just kind of looking by gene, we saw that we have the lowest risk of progression with DNMT3A, particularly when you have a single mutation only in DNMT3A. We also saw that there's the highest risk of transformation when you have mutations in splicing factors, SRSF2, SF3B1, and ZRSR2. These AML-like mutations, RUNX1, IDH1 and 2, and FLT3, and then JAK2, which has a high prevalence, a high penetrance for progression to MPNs. We were surprised that TP53 in this particular cohort did not have an association with myeloid malignancy, and perhaps that's because this is a healthy cohort of individuals with probably very little chemotherapy radiation exposure. However, we empirically included TP53 as a high-risk mutation, and this was because we wanted to sort of, in deriving a model that we would use to exclude low-risk populations, we wanted to err on the side of overcalling rather than undercalling the risk of TP53 mutated CHIP and CCUS. We utilized recursive partitioning, which allowed us to binarize our continuous variables, and we used this in order to bin the individuals in our derivation cohort into groups based on probability of the conditional probability of developing a myeloid malignancy. So the variables that we utilized included various demographic variables, various laboratory variables which were available in the UK Biobank, and various molecular features. To sort of summarize what we saw, we were able to pull out about 8 different features that were important for segregating our population, and the prognosis or the conditional probability of myeloid malignancy ranged from 0.007 to 0.85. So the features that seemed to be important included having one of those mutations that we characterized as high risk, and that includes the empirical inclusion of TP53. Having just a single DNMT3A mutation, which was associated with a lower risk of transformation compared to all other types of CH. Having perturbed or elevated red cell indices, MCV and RDW. Having a variant allele fraction greater than 20%. Having 2 or more mutations, having CCUS instead of CHIP, or having age greater than 65. We put this all together utilizing the regression coefficients to weight our variables, and we created the clonal hematopoiesis risk score, which is available on a web application for all of you all to use. And so basically you input the patient's information, and it tells you whether or not a person is high, intermediate, or low risk based on their CHRS score. The CHRS defined 3 distinct risk strata for CHIP and CCUS, a high-risk group which has a 10-year probability of progression to myeloid malignancy of over 50%, an intermediate risk group which has a 7 to 8% 10-year risk, and a low-risk group which has a less than 1% 10-year risk. We were able then to utilize our UK Biobank validation cohort to validate our model, and then we subsequently were able to use 2 independent clinical cohorts, one from Dana-Farber and one courtesy of Luca Malcavati at the University of Pavia, to clinically validate this cohort. So we also know that CHIP and CCUS are associated with an increased mortality, and so and this is primarily driven by the acquisition or the development of non-malignant diseases, particularly ischemic cardiovascular disease. And so what we wanted to understand was whether or not the clonal hematopoiesis risk score, in being a prognostic model, also correlated with the survival risk in these patients. And indeed, that's what we did see, is that the CHRS groups seemed to estimate mortality, where our high-risk group had a survival probability in the 50% range, and our low-risk group had a survival probability that was more comparable to the individuals without CHIP and CCUS. We subsequently utilized the atherosclerosis risk in communities cohort, the ERIC cohort, which is a slightly older population with a median age of 75, to understand whether or not cardiovascular disease-related death is really the driver of mortality in this population. What we saw was that in this population, about 24.2% of individuals actually had CHIP or CCUS with a VAF of 2% or greater, and then around 5 or 6% of the participants with CHIP and CCUS were high risk for by CHRS. And then when we looked at the hazard for death from high-risk CHIP and CCUS, this hazard was on par with the risk of death from heart failure. And when we looked at the rate of death, or how many deaths we saw related to hematologic death or development of hematologic malignancy, in our high-risk group, sure, there were more deaths related to hematologic malignancy relative to our low-risk group, but by far and away, most of our individuals who died in the high-risk population were dying from cardiovascular disease. So recently, Ben Ebert and I summarized our sort of risk-informed management strategies for clonal hematopoiesis in a review article in Blood, and this is what we do at our Dana-Farber CHIP clinic. So all individuals who come into our clinic have appropriate cytopenia management and are receiving counseling based on their individualized risk for developing a myeloid malignancy or other adverse outcomes. We utilize the CHRS to make the risk determinations. And then our high-risk group is the population that we're monitoring most often. These are the patients that we're considering for inclusion in upcoming clinical trials. We're actually utilizing the CHRS in order to identify or to define eligibility for some of our clinical trials that are in development. And then our low-risk group, because they have both a low risk of mortality related to CH as well as a low risk of transformation to myeloid malignancy, this population really does not need to be followed in a cancer center and can have CBCs with their primary care doctor. We also, in our clinic, are liaised with several internal medicine subspecialists, particularly preventative cardiologists who help get our patients on ACC guidelines-directed prevention strategies for reducing their blood pressure, optimizing their cholesterol, et cetera. And this is with the idea that the major driver of mortality in this population is actually cardiovascular disease related. We have also, with the recent description of VEXAS syndrome, added in the referral to rheumatologists for patients who have symptoms. So in summary here, CHIP and CCUS are subtypes of CH, and these are the ones that are best characterized clinically. The CHRS estimates the risk of myeloid malignancy in CHIP and CCUS, and the subclassification allows us to utilize a risk-informed management strategy for our patients. CHIP and CCUS mortality is primarily from non-malignant comorbidity, and so in the management of these individuals and thinking about prognosis, we're also thinking about modifying risk of non-malignant diseases. And then lastly, I'll leave you with, and we can have this discussion later, the idea that the CHRS was derived in a relatively healthy population, and so there's a specific clinical circumstances, such as what we see primarily at our cancer institutions, where individuals have either prior or concurrent treatment with chemotherapy and radiation that adds a distinct selection pressure to their hematopoietic system that will likely increase the risk over what the CHRS estimates. And so dedicated studies to investigate these special circumstances are needed. Most of the work here was done in the Ben Ebert lab, and thanks clinically to individuals at Dana-Farber in the Center for Early Detection and Interception.
So the next speaker will be Tariq Kewan from Yale, and he'll be speaking about MDS Molecular Classification.
Thank you. Right, I would like to thank the co-chairs for the invitation. I have been given the task to discuss the molecular landscape and classification among myelodysplastic syndrome within 15 minutes, so wish me luck. So myelodysplastic neoplasm syndromes are clonal hematopoietic neoplasm defined by the presence of cytopenia and morphologic dysplasia. In 2009, a small subset of patients with myeloid neoplasm were found to have microdeletion chromosome 4q24 encoding for TIT2. At that time, only 4 MDS patients were included, and 15% of the patients with myeloid neoplasms were found to have TIT2 mutation. Later, with the advent of next-generation sequencing, multiple of these genetic mutations, alterations, and cytogenetics abnormalities were identified among patients with MDS and related neoplasm. And the next question is how we can apply the genomics among patients with MDS. I think the outlines of the lecture can talk about genomic morphologic associations, and the best examples of that will be SF3B1 mutation with ring sideroblast, how these mutations can impact the clinical outcomes, and how we can use the molecular mutation in the unifying the language of a classification. And finally, are these all mutations the same? Are they different among each other? Specifically, when we're talking about the configuration of the similar mutation based on the clonal burden, according to the variable allele frequency, the mutation types, and the mutation locations. Sorry. So first, I will touch base on the correlation between morphology and genomics. As we know, most of the diagnosis of most of the subtypes of MDS require the identification of 10% dysplasia in the bone marrow. And the two best examples to show the association between morphology and molecular mutations is the MDS with ring sideroblast and SF3B1 mutation. And the other one is the hypolobated megakaryocyte among patients with isolated del5q. We know from previous studies that the morphology can correlate very well with survival because patients with ring sideroblast has shown to have better overall survival compared to the patient without ring sideroblast. And based on that, I will touch base about SF3B1 mutation. So as you can see in this cohort of patients, of 533 patients with MDS, around 28% of them were found to have SF3B1 mutation. And those patients with SF3B1 mutation were found to have better median overall survival of 90 months compared to 50 months in the wild type. And this was also true for the leukemia-free survival. But when we looked vice versa among patients with ring sideroblast, we noticed that not all these patients has SF3B1 mutation. Majority of them, about 67%, were found to have SF3B1 mutation. However, in another subgroup of patients were found to have other mutations like SRSF2, P53, or other non-specified mutations. And those patients had poor survival outcome compared to the one with SF3B1 mutation. And even to make it more complex, we know that not all patients with SF3B1 mutation are behaving the same in terms of clinical outcomes. So in this additional analysis done by the IPSSM study cohort, you can see they identified 3 subgroups of SF3B1 mutation based on the presence of other associated mutations, and they defined SF3B1 alpha, where the majority of the patient doesn't have other mutations, or SF3B1 with 5q, and the other one was SF3B1 beta with the other associated mutation I'm highlighting. And as you can see, the better overall survival was mainly associated among patients with SF3B1 alpha. Another good example to illustrate the different configuration of different mutations is the B53, as we have seen during the morning talks. We all know that MDS with B53 is associated with higher risk disease and more progression toward acute myeloid leukemia. However, the allelic status and the configuration does matter. In the first study published by Dr. Brunner from the Sloan Kettering group, they identified a scheme to define multi-hit P53 based on the presence of multiple P53 mutations, or a single mutation with del17P, or with co-neutral loss of heterozygosity. And as you can see in the treatment-related setting, or even in the de novo setting, patient with multi-hit P53 had a poor overall survival compared to the patient with single-hit P53. However, we know that assigning the allelic status is not that easy. For example, as you can see in the first subgroup of patients with a monoallelic P53 and a VAF less than 50%, those patients can be not 100% having a monoallelic P53 mutation due to the presence of subclonal mosaicism. So having a VAF of a 20% have multiple options, including a monoallelic cells of 40%, or even biallelic cells of a 20%, or even a complex of both subclones. So based on that, we conducted a study at the Cleveland Clinic, including a multi-center cohort of 7,400 patients, including more than 1,000 patients with P53 mutation. And we have done a random forced survival analysis in an attempt to identify a cutoff of VAF to predict overall survival. And as you can see, a cutoff VAF of a 23% was found to predict survival. And based on that, we reclassified patients with monoallelic P53 into probably monoallelic, where the VAF was less than 23%, and a probable biallelic, where the VAF was more than 23%. And based on this classification scheme, you can see the patients who were assigned to monoallelic have a better overall survival and more comparable to the wild type. However, the patients who were probably biallelic had a worse overall survival, although it was much better than patients with obligatory biallelic via the traditional schemes. So with that, I will touch base with the classification implication of the genomics in a classification, as was discussed by Dr. Mina. As you can see, both ICC and WHO have included SF3B1 mutation, deletion of MDS with 5EQ deletion, and P53. However, there are some similarities, particularly in the identification of dysplasia that was kept by the WHO. More importantly, you can see the more controversy present in the P53 allelic status assignment. I would like to highlight the differences here in the ICC is that P53 mutation multi-hit was considered among patients with single P53 mutation and complex karyotype in the ICC as a pi-allelic equivalent. Also, ICC excluded all patients with VAF less than 10%. And finally, ICC did not actually, WHO did not define MDS/AML as presented by the ICC classification. So in order to imply all these genomic and their impact on the outcomes, recently the novel IPSSM was discovered by the Sloan Kettering group, by the IWS group. And as you can see, they included 2,957 patients from the IWG cohort. They included the clinical data and molecular data in order to look at 3 endpoints, including leukemia-free survival, overall survival, and AML transformation. Important to mention, they included 17 binary variables among the other clinical variables. From these were 16 prognostic, and they accounted for the TP53 allelic status and the SF3B1 alpha subgroup, as I mentioned. And as you can see, the only subgroup or the only genetic mutations that were associated with good prognosis was the SF3B1 alpha subgroup. So 6 risk categories were identified from very low risk to very high risk. And as you can see, there was significant difference in terms of leukemia-free survival, overall survival between the risk groups. IPSSM resulted in restratification of 47% of the patient, and most of these patients, more than 70%, were upstaged. Importantly, when the IPSSM was compared with IPSSR, according to the C-index, which actually measuring the performance of the model, IPSSM led to more than 5 percentage point increase in the C-index for all clinical points when compared to IPSSR. Multiple validation like cohort have been done, and studies including the one in Cleveland Clinic, and we have shown that like the validation of IPSSM among patients with high-risk disease treated with HMA is not very well established. So with that, I would like to consider some of these limitations that led to our machine learning study. So we know that the clinical morphological and cytogenetic features have dominated the pathological classification of myelodysplastic syndrome until recently when we started to see the molecular defined subtypes in the WHO and the ICC. And when we consider the molecular feature, the morphology-based classification always overemphasize on variables that stress on the prognosis, such as the blast, which may represent the stage of disease rather than the pathophysiology of the disease. Prognosis impact as a discriminator and using a prognosis in order to do the classification will not identify pathway that can have divergence or convergence. Very simply because patients with different mutation with different function can be clumped to the same clusters which have same prognosis. So based on that, new strategies will be needed to deconvolute the molecular heterogeneity and complexity and identify molecular clusters and then try to estimate the prognosis based on these molecular clusters. And with that hypothesis, I will talk about our molecular pattern that identify distinct subclasses among myeloid neoplasms. In this study done in a multi-center cohort from Cleveland Clinic, MLL, and other public data, we included about 3,500 patients of MDS/secondary AML, and we use only molecular alterations and cytogenetics abnormality by using machine learning method of unsupervised clustering to cluster these patients into molecular cluster. As you can see, the model was agnostic to outcomes, and we did not include the blast percentage. We did not include any clinical data. The model was internally validated by 5-fold cross-validation to emphasize the integrity, and also it was externally validated among 400 patients from 2 external cohorts from Case Western and Wayne State University. We identified 14 molecular clusters, and the table is showing the characteristics, the morphologic characteristic and the labs at the baseline. As you can see, those clusters were phenotypically significantly different between each others. For example, molecular cluster 11, they have more thrombocytopenia, more like a blast compared to other clusters, and the clusters has significant differences in terms of demographic, including age and gender. This is a busy slide showing the molecular features of each of these clusters. But I would like to emphasize that all these clusters were heterogeneous in terms of composition of low-risk MDS, high-risk MDS, or secondary acute myeloid leukemia. So if you can see, each one of these clusters contain patients from these three subgroups of morphologically defined myeloid neoplasms. However, the high-risk secondary AML-like groups were enriched in molecular cluster 1311, and some of the low-risk molecular clusters, including 4 and the cluster number 2, included more patients with low-risk disease. So the heat map is showing the distribution of different molecular alterations and cytogenetics abnormality among the different clusters. And as you can see, patients with same molecular mutation can be assigned to different molecular clusters based on the other associated mutations. So for example, if you take patients with P53 mutation, they can be assigned to molecular cluster 13 if they have complex karyotype or other high-risk cytogenetics, or they can be assigned to molecular cluster 8 if they do have deletion 5q or TIT2 mutation. Patients with SF3B1 mutation can be assigned to different clusters based on the presence of normal karyotype, TIT2 mutation, or even the presence of ASXL1 mutation. We then identified the most important molecular feature that will increase the probability of assigning patient to one cluster versus the other. And based on that, we pointed out in the table the most important signatures to identify each one of these clusters. In order to determine that these clusters are biologically different in terms of overall survival, we did a match pairwise comparison in terms of overall survival. And as you can see, there was significant differences between the clusters. We then grouped the clusters with same median overall survival together and identified 5 distinct risk groups. As you can see in the Kaplan-Meier in the upper panel, these risk groups were significantly different in terms of overall survival, and this was also true among the validation cohort. Finally, a similar kind of methodology was adopted by the IWG cohort that was presented recently at ASH 2023 as an abstract by Dr. Brunner, in which they look at molecular taxonomy among patients with MDS. They include about 3,200 patients, treatment-naive patients with MDS, and they look at gene mutations and copy number alterations and copy number loss of heterozygosity among 152 genes. As you can see, they accounted for allelic status of P53 and TIT2 at the time of the input. Also, they looked for some hotspots and some copy neutral loss of heterozygosity. And they identified 18 subgroups. They subdivided them into 5 distinct categories based on the previously defined molecular features. The heat map is showing the phenotypic features of these molecular subgroups. And as you can see, they are phenotypically different. For example, patients with P53 complex karyotype were more enriched with a blast and more neutropenia anemia. Patients with MDS SF3B1, they have more anemia. Patients with DIL5EQ have more anemia. By TIT2, for example, they have more monocytosis, coinciding with previous literature. And more importantly, these clusters were having overall survival differences and leukemia transformation differences. Also, within the patient assigned to the same molecular cluster, you can see that different diagnoses based on the morphology, like primary MDS, treatment-related, or even overlap syndrome, have similar overall survival. So with that, I will conclude that genomic clustering allow the identification of distinct MDS molecular subgroup associated with specific pathomorphological features and outcomes. We need future model to include a clonal burden of different mutations, the type of the mutations, and configuration of each individual mutation, and maybe the germline mutation, to have more precise clustering and classification. And finally, classification of MDS based on genomic features is really challenging due to the complexity and the heterogeneity of the mutation, but can significantly impact the clinical decisions, classification, and the future designing of clinical trials. Thank you very much, and I would like to thank my mentors, Dr. Mashelsky, Dr. Zaidan, and I will be happy to answer any questions after.
I'd like to now invite up our next speaker, Luca Lanino. He'll be talking about harmonizing WHO and ICC MDS classification.
Good morning, everybody. Thank you for the kind invitation to discuss the harmonization of WHO and ICC MDS classification. So we have seen extensively why we should harmonize these two classifications that were released in 2022. We've seen how the implementation of molecular analysis in the diagnostic process has enhanced its performances. Hopefully in the future we'll see how we can best choose treatment for this patient according to molecular information. We've also seen how the coexistence of these two classification schemes can potentially impair our discussion with our patients, how we discuss with colleagues, how we deem patient eligible for clinical trials. And so I think we can all be concordant on saying that harmonizing and maybe finding a unified classification is a mandatory task for our patients. How can we harmonize this classification? On behalf of the International Consortium for MDS, we devised a project, and to do so, we implemented the so-called Mosaic framework. This is a framework based on artificial intelligence and machine learning approaches that tries and define a group of patients defined by homogeneous genomic signatures. This is an unsupervised model, so the algorithm is only fed mutation data and cytogenetic abnormalities. On the basis of this data, it's able to classify patient, and most importantly, we also applied explainability tools. In this particular case, we used the so-called SHAP, so this is a game theory-based approach that tries to open up the black box of the algorithm and see which individual features are most important for the allocation of a single patient to this or that cluster. A paper concerning this framework is now been accepted in JCO-CCI, and together with the publication, we will also release the source code for the model, so if anyone is interested in applying this to other entities, that will be great, I think. This was a huge collaboration that included the European Consortium GenoMed for All and also patients from the Moffitt Cancer Center in Tampa, Florida. We collected more than 7,000 patients with MDS defined according to 2016 classification, for which clinical data, cytogenetic abnormalities, molecular information, and survival data were available. First step of the project was to reclassify all the patients according to the 2022 classification. Now you can see that, and was shown before, the two are not concordant. There are entities described in one that are not present in the other. Big jumps from low to high risk entities is not the normality, but it's seen. And if you look at numbers, we see that concordancy is pretty high for genetically defined entities, but can be as high as 40% for morphologically defined entities. Most importantly, I think that the fact that a patient can be classified as having AML with one classification and not the other is one of the most relevant problems that we're faced with using two different schemes. So applying the hierarchical clustering, and we were able to define 9 distinct population of patients defined by the co-occurrence of homogeneous genomic signatures. This was the basis to define a hierarchical algorithm for classification of patients, somehow in a similar way as it was done for the 2022 ELN guidelines for acute myeloid leukemia. First, we looked at the features that were most relevant for classification in the in a genomically defined cluster. We started with MDS with TP53 mutation. The most important feature, of course, was the presence of a TP53 mutation and the presence of a biallelic inactivation, defined as the presence of 2 or more mutation or 1 mutation with copy number variation. Most patients in this cluster also harbored complex karyotype. Median VAF for TP53 mutation was more than 10%, and assignment was irrespective of blast count, even if most patients showed blast success. Interestingly, patients with monoallelic TP53 mutation were preferentially clustered elsewhere, most likely because of different pattern of commutations. As we'll see later, in this cluster, the algorithm included also patients who harbor a mutation in SF3B1 and a deletion of 5q. Deletion of 5q cluster is in fact the second cluster we looked at. the major genomic features according to SHAP analysis that were important for allocation to this cluster were the presence of deletion 5q and the absence of chromosome 7 abnormalities and of a complex karyotype. Most patients didn't show blast success. Patients were included in this cluster even if they had a concurrent SF3B1 mutation, but not if they had biallelic TP53. The third one, the cluster of MDS with SF3B1 mutation, was defined according to SHAP analysis by the presence of SF3B1 and the absence of RANKS1 mutation, abnormalities of chromosome 3 or 7, and a complex karyotype. As expected, the vast majority of cases had less than 5% blast, but we saw in almost a third of the patient mutation in genes associated with clonal hematopoiesis, such as TNMT3A and TAT2. We then looked at morphologically defined MDS entities according to the cluster assignments. We see there is no genomic signature that is able to identify homogeneous groups. This is true for blasts less than 5% and blasts more than 5%, and also for a number of dysplastic lineages in the presence of hypoplasia or fibrosis. Finally, to better understand the biological continuum between high-risk MDS, that is MDS with more than 10% blast, and AML, we interrogated a cohort of more than 1,000 patients affected by AML according to 2016 criteria with the same methods I described before. We were able to observe some overlap in between these two groups, most importantly in AML, in MDS with AML-like mutations such as NPM1, and also between MDS and AML with myelodysplasia-related changes. Overall, the overlap was around 30%, and we were able to, to confirm that a 10% threshold might not be able to capture different biological entities. So, since we were not able to define harmonized label for morphological defined MDS using our data-driven approach, we employed a consensus process based on a modified Delphi that included 71 expert hematologists and hematopathologists from 11 countries. And after 2 rounds of consensus, we were able to define disease entities, such as having both a prognostic and therapeutic impact and diagnostic qualifiers, those having only a prognostic or therapeutic impact. The morphological disease entities were defined were MDS with low blast, MDS with increased blast 1/MDS with EB, and MDS with increased blast 2, or MDS AML. We also defined diagnostic qualifier, including a number of dysplastic lineages, the presence of hypoplasia and fibrosis, the presence of ring sideroblast, and a history of chemotherapy or radiotherapy, and presence of germline predisposition. Finally, sorry, don't know what happened here, but I'll try it now. Whatever. This is now the algorithm failed somehow, somewhere. It was looking very good on my PowerPoint, I assure you. But anyway, let's see if I can walk you through it. We define a hierarchical algorithm for classification of MDS that tries and harmonize the ICC and WHO. So starting with a patient that meets criteria for MDS, that is cytopenia and presence of morphologic dysplasia, we suggest first looking at the presence of TP53 and then checking for disease-defining criteria for TP53. That would be the presence of biallelic inactivation. For deletion of 5q, that would be the absence of a complex karyotype abnormalities in chromosome 7, and for SF3B1, the same as the Q with the addition of the absence of RANKS1 mutation and abnormalities of chromosome 3. Once we've excluded these 3 genomically defined entities, we can then look at blast count and define MDS with low blast and increased blast. With the help of addition of diagnostic qualifier that try and reconcile the WHO and ICC maintaining morphological entities such as fibrosis and hypoplasia, and the presence of ring sideroblasts, which is especially important for treatment, especially in Europe. So to summarize, we think that a data-driven approach can generate solid evidence for the harmonization of classification in MDS, and most likely also in other hematological and non-hematological diseases. I think a hierarchical algorithm can help clinicians, pathologists, and also patients understand how we should classify patients and improve our real-world practice every day. Morphological MDS entities are defined according to the 2022 classification are not characterized by homogeneous morphological signatures. Tariq showed us ongoing efforts to try and find new entities that will most likely be defined in coming classification. And I think the Mosaic framework has proved useful in this project and may prove useful in projects in the future. With this, I would like to thank all the co-authors that participated in this study and the Foundation for the kind invite. Thank you.
And then I'd like to ask our last speaker to come up. This is Brunner from MGH, and Andy will be speaking to us about MDS Response Criteria.
Hello. Thank you so much for having me. It's a pleasure to join this meeting, and hopefully this is a very timely talk. Now we've just reflected on this heterogeneity of how we classify and provide prognosis in MDS, and I'm hoping to talk a little bit about, once we start to treat patients, what have these updates done to how we think about responses to disease treatment and what might lie ahead in the future. So here's my disclosures. So I'm a clinical investigator, and I see patients primarily with MDS in my clinic. We use treatment responses both in clinical research and in patient care to kind of create a common vernacular, a language that we can communicate with one another. We want them to be meaningful. In clinical research, we're using them to try to identify what drugs are actually active in this disease. Is there a benchmark that we can compare to say something is better or worse than what exists right now for treatment? And in patient care, we're often using these markers to say, hey, look, you have had a complete remission. That is great. It means that you're likely to have a longer time with that response, and patients may have a longer survival if they have a response, or we may think about a goal of a response before you go to transplant. And so integrated all that is this idea that somehow these responses are meaningful and that they are consistent and that they mean something to the disease biology. And the reality is that MDS is an interesting response criteria. It's an interesting blend of largely low-risk needs, which are improving blood counts. So do you have transfusion independence? Does your hemoglobin go up? As well as high-risk or frankly, AML-type responses. If you have an increased number of blasts, do those blasts go away? And trying to fuse those together creates a lot of heterogeneity in what we view as a benefit or not, depending on what patient is in front of you. And I think it was great to have this review of how complex and how heterogeneous MDS is. And on the clinician side, we often are meeting somebody and we're trying to prognosticate what's likely to happen to your disease over time. Are you going to live with this, or is this going to become an immediate problem? And do we really need to intervene, treat it, and try to prolong your life or improve your response? And I think that this was a analysis of a trial used azacitidine plus sabatolimab, but this could be any cohort of patients, just showing how our prognostic scores have evolved over time. And I'm belaboring prognostic scores because when we choose a patient to go onto a trial, or when we choose a therapy for somebody, we're usually choosing them because their disease is high risk, is poor prognosis. And you can see that when a lot of our therapies were initially developed, we used the IPSS, the risk of that disease was largely from blasts. So if you had a high blast count, that's what weighted your risk. That's what got patients into trials. It included patients with oligoblastic AML with 20 to 30% blasts. And that is reflected in how we think about responses to treatment, because if you have a bunch of patients with increased blasts, then blast-based responses are going to be more relevant. But as we shift over now, our risk is largely molecular. Blood counts still matter and blasts still matter, but we've reduced the number of blasts to 20% for MDS definition. And most of our disease risk that includes patients on a study or on a treatment paradigm like azacitidine or decitabine is based less on their blast count and more on this molecular risk. And it's less clear whether these are the same patients that we would have treated 20 years ago. And it's not bad. This is a much better discriminatory system, right? We can distinguish people who have very low risk disease they're going to live with their MDS. My job is to not impact your life too much and to figure out what is the problem that the MDS is contributing and how can I mitigate that symptom. And then it's also very good at finding patients where within a year or two, if we don't do anything, you may die from your disease or from a complication related to having MDS. And so it's definitely an improved understanding of the heterogeneity of this disease, but it does require us to reflect a little bit about what are we trying to get out of a treatment when we look for a response and when we look for drug activity. And I think that this idea of blast response versus hematologic response is one that I'll kind of keep coming back to. Because so many of our response criteria are around this idea of getting rid of blasts, that is a core element for how we assess a response from the top, especially for higher risk disease. But if you look at, how much of a problem is blast, is leukemia even in MDS, even in the highest risk, the very high risk group in this, in our new IPSSM, less than half of patients actually progress to AML. And the mortality is very high, but it's not necessarily a blast-based risk. And yet, when we think about what are we trying to develop drugs for this disease in, we're really using blasts as an anchoring point. Similarly, we don't have a good sense of what patients we're bringing onto studies anymore. This was a study that we did looking at a bunch of monotherapy trials of azacitidine or decitabine, essentially showing that the historical benchmark for CR rate is somewhere around 15 to 20%. And yet here we are, and we've had now 5 phase 3 studies, several of which have been beating our expectations. Our CR rate and the patients we include on trial may be part of why, but our CR rates are higher, including over 30%. And so when we're trying to design studies to identify meaningful improvements in drug treatment paradigms, we are not necessarily including the same patients that we included years ago to create our historical benchmarks. Now, I do think we've had some improvements in our response criteria, and we've learned. And I look at low-risk MDS really as a space where we have understood the heterogeneity of disease and how response criteria really need to reflect that you're bringing a lot of people onto trial that have different backgrounds and different treatment needs, and that they are reflected. And one example is how we assess red cell transfusion improvement. And I think that the 2018 update defines people into this no transfusion burden, low transfusion burden, and high transfusion burden based on several months of transfusion needs before you start an intervention. And that kind of reflects the heterogeneity that we see. If you have a patient who only needs 1 transfusion every 2 to 3 months, that patient is not going to have the same expected benefit as somebody who's in your clinic every week for a unit of blood. That the goal should be different for each of those patients. And I think we've seen that reflect into real clinical trial outcome implications. So here are 2 trials, and I think an interesting factor is that neither of them used the new 2018 response criteria. That said, if you think about matching disease responses to your patient population, they both did it a little differently. So you can see the COMMANDS trial. It is looking at a frontline MDS population. It is lower risk. These are patients who had transfusion needs. And because they're earlier in this transfusion burden, the overall need was low. And so even though it's not separated by transfusion dependence, the goal, the benchmark that they needed to hit was higher. So they had to have 12 weeks of transfusion independence, and they had to have an improvement of 1.5 grams per deciliter in hemoglobin. So there's a pretty high bar that's reasonable for early phase disease. And you can see that luspatercept had a higher rate than ESA in the whole cohort. In contrast, at ASH last year, we also saw a study, a similar population, to be honest. It was generally lower transfusion burden patients. It was comparing roxadustat to placebo. And the remarkable thing about this, to me, is 8-week TI was the endpoint, but the placebo group had a 33% rate of transfusion independence. And so when your placebo group is hitting that high of a response, you've chosen the endpoint's not a meaningful endpoint for that disease state. And so can we learn from this need for understanding the heterogeneity of disease and responses also in high-risk disease? And we're getting there. We have some updates. If you have more than 5% blasts, I think we're much more aligned with AML response criteria now. So this is a little algorithm of based on your baseline blasts, how would you assess a response to treatment? And you can see that we're more aligned with how AML responses are. But this is just with over 5% blasts. In contrast, if you have less than 5% blasts, it's really hard to get a response. So the only CR equivalent that you can get is complete cytogenetic clearance. So you have to have molecular or cytogenetic clearance. It's not even molecular clearance. We don't really have a 5% cutoff. There's no perfect thing except for this high bar. And again, if we have now taken away most of our excess blast patients from our trials, moved in molecular risk, getting a response with this might be hard. We might be actually hurting our chance of response rate unless you have HI, unless you're eligible for HI, which again depends on having baseline cytopenias. So it is an interesting challenge that we face because we exist with this blast dependence as our main driver of response. Do you have enough blasts to be eligible for a response using these criteria? And the other challenge that we're facing is that we've moved our blast number down from 30% to 20%. And now with MDS AML, if we moved it down to 10%, can you even have a partial response at 10%? Not really. And so suddenly, the number of patients that we are including on studies for high-risk MDS we're really leaning into molecular risk and removing all the patients that might respond to our blast response criteria. And so, can we look at other intermediate response metrics as ways of identifying patient benefit? This is one nice thing about CR or a Marrow response is that it's fast. It happens, within a couple months of starting somebody on treatment. You do another bone marrow biopsy, you can see if the blast went away or not. So it's an early metric that you can use for identifying active compounds. But hematologic responses matter, and it may be that we can use a more broad understanding of hematologic benefits. This is from AZA-001. It shows that patients who had HI but no bone marrow response, they also had significant survival benefit. And I think when we are thinking about more molecular risk, we might need to use more hematologic benefit in our high-risk studies. Similarly, what is the actual cutoff that we need for hematologic benefit? And I think increasingly we're understanding that the bars we set for what is hematologic improvement are very high in MDS, but you may not need that much. We looked at a study with can we reassess people as CRH? So if you have 50,000 platelets, 500 neutrophils, most of the time you're out of the woods for complications. Is that a good enough response? And we found that they did as well as CR. And recently, a big effort, multi-center international effort, looked at many patients for their response using various different metrics, CR, but also unilineage improvement, bilineage, hematopoietic improvement. And you can see here on this graph that they're all overlapping. So if you have any blood improvement, it seems like you do pretty well. And so is it less of a range of benefit, and is it more about just getting a bottom basement that if you get people up to a certain level, they do well with therapy? And is that a way that we can identify therapies that are meaningful in MDS? So where are we in high-risk MDS? Well, it's complicated. We're still more complicated than AML. And we still don't necessarily align responses the way that AML does. AML responses are, they're non-overlapping. Patients get one response. They don't have multiple. We're still not quite there in MDS, but we're getting better. I think especially for excess blast MDS, we're more aligned with AML. I think that the one area that it would be nice to start to explore more is whether time to event is a meaningful endpoint in MDS. We've only got one therapy or one therapeutic strategy in high-risk disease, right? HMA-based therapy. But as more therapies are developed in AML, and as more people can be salvaged, perhaps post-azacitidine or decitabine, do we need to start considering crossover designs in our trials or PFS as a meaningful endpoint? Because it is a little bit of a to-do when people have to change therapies. Is that something that would be a route for identifying meaningful drug benefit in MDS? And so, to conclude, I think we've made a lot of updates in 2018 and 2023 that reflect this much better understanding of the heterogeneity of MDS. In low-risk MDS, the HI criteria, they do consider heterogeneity. So far, our trials have just been constant endpoints. Did you get 8 weeks? Did you get 12 weeks? And we're not using this variable that's tailored to the patients. And so, can we move into that direction? Should we move into that direction? For high-risk MDS, we really are still pretty heavily reliant on a blast improvement as in our criteria. And is that the most appropriate criteria since we're moving into really a space of molecular risk? We're still too complex for our response criteria, I would argue. We have all these dynamic improvements over 8 weeks that you have to assess, over 16 weeks. And it's a very complicated assessment. Would it be better just to have a standard minimum? If you get platelets over 30, great, we did it. But we have to validate that prospectively. And should we be more explicit about our goals? Which treatments are really trying to reduce blasts, and how do we move more toward improving marrow failure? And then I think for designing trials, we might need to think about how we consider crossover or early response metrics in this disease. So we still have a big need for new therapies in MDS. I'm hoping that our response criteria improve that pipeline, and look forward to any questions. Thank you.
Thank you so much for our speakers, great talks. We'll have around 10 minutes for questions.
Yeah, those were really great talks, and I just want to make a couple of comments and ask a question. So the first comment is for Andy Brunner. Great talk, hard topic. I mean, if I was the FDA and I heard you talk, I'd be crying, because what they have to do is figure out whether a patient can benefit, either in terms of quality of life, live better or live longer. Okay, so that in MDS, particularly the survival, especially in high-risk MDS, has got to be the endpoint. Endpoints of CR rate, we know from all the phase 3 trials that failed. Very excited about nobody's mentioned the word magrolimab, but we have to know, an APR 246, we have to understand our failures. The CR rates were high, it didn't translate into survival benefit. And with low-risk MDS, yes, transfusional burden is an objective endpoint. But you and I have taken care of a lot of MDS patients. How many patients are fatigued beyond all knowledge to their own life without much anemia? Or if you fix their anemia with a drug that may cause fatigue, they're no better off. So we need a better quality of life instrument. And Dr. Abel at our place is working on that. But my question to Tariq and to Luca is about, why do we care about multiple classification systems? Do we really care about them? I mean, all I care about is prediction. I want to know, the patients care about prognosis a little bit, not too much, because you just make them feel badly. Really, I mean, you can get their life in order. They can get their life in order if they have a p53 mutation, but that's about it. What they care about is what therapy you're going to give me, Dr. Weeks. So the prediction is very important, and we have to remember that clinical trials, however bad they are based on prediction. So if we have the FANOS trial was based on IPSS criteria that were developed by in 1998, and that's all we can really use to say a patient is going to benefit or not from azacitidine. If they are in the high-risk classification system by Bernard's work and Papa Manuel's work, does that mean they should automatically get azacitidine if they were not high risk per the FANO paper? I think that's a central question. But my question is for both for Tariq and for Luca is, are these you've tried to get a functional classification of MDS, which I think is really important because at the end of the day we need to understand the biology and apply the therapy specifically to biological groups. We've learned that in AML, in spades, obviously. So, have you guys talked and figured out whether your biological clusters fit with the harmonized thing or anything else we can use clinically? Because then those if they're really biologically valid clusters, those should be the criteria for going to clinical trial.
Yeah, sure. Thank you for your question. Maybe I can start and then Luca can elaborate. So I think, so if you look at like the harmonization, you can see some of these clusters like were identified by allelic P53 mutation, MDS like 5EQ, SF3B1, which is similar to the clusters like we identified by the functional like clustering. Also in the study published by Dr. Bernard, like in ASH in the abstract, we identified similar like biological and functional cluster. But to your question, I think that's what we are lacking in MDS, specifically in the high risk, that we are using the same kind of a treatment for all patients with different like background of like mutations. And I think we need to find a targeted kind of like a treatment for these patients in order to like find the benefit. And the way to do that is by like trying to understand the pathophysiology of disease and the association between different mutations, or for example, novel kind of like mutations associated with each other. So we can try to understand how the disease is evolving and how this can affect the phenotype, and whether we can find target treatment for these type of patients.
We'll talk about that this afternoon with regard to luspatercept and SF3B1 and how that trial was constructed.
Yeah, I hope that this answers your question.
I just wanted to add that at the end of the day, we will always need classification, I think, because we will need to speak the same language. We only need maybe to change or improve, update the way we classify patients. I think the techniques we showed may somehow improve, maybe rely more on the biology of diseases and less on the way they appear under a microscope, or maybe pull together all of it, but we will always need classification, or maybe you suggest implementing stratification of risk more in the classification? I don't know.
I don't really read I'm glad the pathologists put the three classifications as they do at Brigham when they see me, but all I care about is the cytogenetics, the blood counts, the molecular, and how the patient feels. So the words are important, it's the function that counts.
So before we go to Yorick, I just want to make a quick comment and let also Andy answer. So I think it's important to realize two things with the response criteria. So a lot of the effort is actually on early phase trials, right? Because everybody agrees that once you go to the phase 3, your endpoint is supposed to be overall survival in high-risk MDS. But the real question for response criteria is which drug do you move from a phase 1 trial to a phase 3 trial? And what was going on, and you are absolutely right, is that Marrow CR was taking many drugs from phase 1 to phase 3, and everything is failing. And I just want to make a point about the CR. I don't think the problem is actually in the CR. I think what happens is that many of the drugs that get promoted as very exciting, when they present in the first ASH meeting, the CR is 50% on 40 patients. Next ASH is 40%. The phase 3 is already going. By the third ASH update, the CR rate is 30%. And what...
That's a poster.
Yeah, so this is what happens most of the time. So what I can make a bet for is that if you hit a CR rate of 50% in a phase 3, your OS is going to be positive. The problem is that we are not getting reliable OS. This is one thing. The other thing is that the central versus the investigator CR, there's a lot of heterogeneity in that. I think when you are doing it in a more stringent central way, that's a more reliable CR. So I think these are some of the things that go in, but the idea of the response criteria is more about how to move into the, And the second point I wanted to make regarding the lower risk, I think some of this will be discussed in the afternoon, but this is actually very fascinating with the whole, anybody who watched the ODAC meeting on imetelstat, it was full of all of this discussion about what is meaningful in lower risk MDS. And I can tell you, the FDA is already starting to think about moving that bar from the 8-week transfusion independence. You can see that, but the question again is, you cannot improve overall survival in lower risk MDS currently with any therapy we know. So we have to rely on proximate endpoints, and improvement in quality of life has been so difficult to again manifest because you are still giving these patients blood transfusions. I always say if you prevent the placebo arm from getting blood transfusions, I bet you the quality of life is going to be better in the intervention arm. So I think these are some of the difficulties that we kind of face when we assess responses. Yuri?
Yeah, I agree on response criteria. For instance, the macrolizumab, we are talking what is a societal risk of assigning response that then promotes the subsequent trial and sale of a company for $6 billion that could be spent actually to cure cancer, right? These are market forces, but the central review silos it and actually makes it wrong. So I would push back on your argument that it should be central, because it's exactly the silosing and presenting phase 2 data in a super positive light based on bogus criteria that hopefully you are going to change, that is recognized by everybody, would prevent this type of hype that then subsequently is self-perpetuating, pathway to the phase 3 trial and ultimately a failure. In terms of my comment in terms of the IPSSM is that most of the patients were untreated, and this is a very complicated issue, because if they were low-risk patients, they were untreated. Many of them, with a follow-up of 5 years, eventually got MDS, so they still were untreated, or they were. These type of studies have only a granularity that goes this far because it's impossible to assert all of this. But what does it mean is that if you take the treated patients, there was no advantage of any of the mutations. It was marginal in the confirmatory studies, whether you use IPSSM or IPSSR, and only advantage was in patients who were untreated. So if you want to derive the prognosis for the patient based on this, it's a little bit dishonest, because we are living in 21st century, right? You cannot, we had meetings about classification of CML until Gleevec came, right? And all of this, right? How many meetings about classification of CML you had since Gleevec was approved, right? This, I think, reflects our inability to produce more drugs and better treatment. And definitely, in today's day, the classification schemes based on prognosis should not be used on untreated patients. I don't know how it would help. You are going to pretend if we would not treat you. Imagine it, you add it to antibiotics. Yeah, you have urinary tract infection. If we don't give you, Cipro, you end up with a kidney abscess. It's really difficult. It is going to be changed.
No, I fully agree, and I don't know who wants to take this.
No. I was going to say, it's a great point. I think both comments, both of you make that, and maybe to contrast with AML. AML, ELN risk criteria are largely based out of clinical trials with all treated patients where you have response to therapy as the guiding prognostic differentiator. And in MDS, we do kind of the opposite. We use our prognostication to say whether you should go on a treatment. We have not done as much to try to identify subgroups, except for P53 perhaps, but we haven't done such a great job of treating that either. But using therapy-based outcomes to decide groups in need for novel therapeutic measures, we haven't done as much of that as a group. Like FLT3 is a great example of a disease that used to be terrible and has steadily moved up as we view it as a distinct entity in AML. And so can we do the same thing? Should we be doing the same thing in MDS for each of these groups based on therapeutic response? I don't know.
I just want to say a quick thing about the classification. Now that everyone's trashed classification is useless and the prognosis, I do think that actually classification does have value. Identifying potential entities, if you're trying new drugs, that there could be a signal in one. If you have a really good biologic group, like say MDS deletion 5q, the response to lenalidomide, not because it's just a good prognosis MDS, it's because of the specific type of MDS that it is, the biologic type. So I think if we define biologic types, I think in the future we may be able to find better treatments that gear to those specific subtypes.
And I just wanted to add a quick comment to your point. So I agree with you. I think one of the struggles I have with the prognostic systems, many of them kind of mingle. Either they use untreated patients, so you don't know what does that mean in the context of treatment, or they mix patients, and then if you have a drug that alters the natural history, like HMAs, like how does that impact in terms of the prognostic tool? And for that reason, we actually started the Validate effort, which is going to have close to 3,000 to 4,000 patients. All of them received azacitidine or decitabine to try to make it more homogeneous. And in that context, actually, Tariq presented in ASH that the IPSSM is still prognostic in that context among high-risk patients who are, all of them are getting HMA treatment. But for me, the main conclusion was the high and very high risk within the IPSSM among HMA-treated patients, the median survival is actually only 14 months. So it's still very poor. So I think this is information that you can tell the patient, but more importantly, this could be, in my mind, a group of patients that everybody should be considered for trial, but people who clearly have very poor prognosis with these prognostic scores should be even more considered for clinical trial enrollment. And at one point, we might want to think about something beyond HMAs. I think this is the next phase of trials that is going to happen in MDS, especially if Verona does not hit. Hopefully it will hit, but we'll see. Any other questions? I know everybody is hungry and looking for lunch, so if there are no questions, we'll get to lunch. Thank you so much.